All right, so guess what? Surgery is not always successful. You knew that. And yet we've gotten so good at doing these techniques that it kind of gives the impression that you're guaranteed a successful result. But what does that even mean, a successful result? At the end of the day, surgical success depends upon whether the patient is satisfied or not. And that's, sort of the final metric. You can measure, anatomy before and compare it to anatomy after and use that as a way to define success. But if the patient's not satisfied, your surgery was not successful, right? And I'm well aware that there is just no way you're going to satisfy everyone, right? Having done thousands and thousands of procedures, and being quite good at these procedures, I can tell you there is a finite failure rate for these procedures. But the good news is, in general, the success rates are pretty high, 80, 85%, long-term, multi-year success. Still, that implies 15 to 20% chance that you won't be satisfied with the surgical outcome or entirely satisfied with the surgical outcome. And that may sound like a pretty good deal. 80% probability of getting what I want, darn good deal. Unless you're in the 20%. Because when you're in that 20%, it doesn't feel like 20%. It feels like 100% of your experience. And so, keep that in mind. How will you feel after going through a procedure and the convalescence for weeks afterwards if your symptoms aren't improved? And how would you feel if in addition to that your symptoms are even worse, or now you have new symptoms you didn't have before, right? Like maybe you were having an uncomfortable bulging sensation or a heaviness in the pelvis, and that's mostly resolved, but now intercourse is too painful to enjoy. These are real possibilities. They're not the probability. But they can and do sometimes happen and sometimes require more surgery to try and fix them. And even then, it's not a guarantee. So consider these questions. How you feel if the symptoms you want to get rid of are still there, and how will you feel if afterwards you have new symptoms you didn't have before that are even more bothersome than where you started? Because that is a possibility. Let's talk a little bit more specifically about what the risks of surgery for pelvic organ prolapse actually are. There are a number of them, some of them more common than others, but you should probably, if nothing else, understand the risks and how commonly bad outcomes or undesired outcomes occur. So, number one, infection. Anytime you make an incision in the skin, you're giving bacteria an opportunity to be introduced to the body in a way that could allow them to establish an infection. Now, almost always postoperative infections are treatable without further surgery, usually with oral antibiotics. The most common after pelvic reconstructive surgery would be a urinary tract infection. And usually that can be treated quite effectively with 7 days of an oral antibiotic. Symptoms resolve and don't come back. That's great. Not always. Sometimes a urinary tract infection, unfortunately, can affect more than the bladder. In fact, it can move up the ureters into the kidneys, and then even from there into the blood, creating something called urosepsis, which unfortunately has a very high mortality rate. And so, again, that's rare, but if it's you, it doesn't feel rare, and it should be considered. This is a surgical risk, and you'd certainly want to let your doctor know right away after surgery if it seems like since your surgery, urination is becoming more frequent, you're experiencing burning with urination, if there's blood in the urine, and absolutely if you have back pain or fever, you've got to let your doc know right away. Just time is of the essence. Number two, bleeding. Of course, that's a surgical risk. That may be the first one that comes to mind. Having bleeding that we'd consider to be a hemorrhage, right? That bleeding on that scale is really rare with these procedures. right? But the risk is depending on who's doing the surgery, probably less than 1%. But if you're a surgeon that's doing 300 of these a year, you're going to experience, not you, but a surgeon will have a patient who has had this complication. Now, that generally happens during the surgery and can be addressed, right? You can stop the bleeding, and if you have to, even give blood products if the blood loss has been so great that the patient would be significantly anemic, right? And that's great to be able to get a handle on the problem during the surgery, but sometimes bleeding happens after surgery. And again, this is true regardless of who's doing the surgery. Postoperative bleeding is a risk. And in those cases, if you develop a hematoma, which is a collection of blood that is walled off because it's inside the surgical space around the vagina, that can be a little bit easier to deal with than if the bleeding is inside the abdominal cavity, right? And so, vaginal reconstructive surgery, the surgery is done through the vagina but without entering the abdominal cavity, might be a way to reduce the risk of hemorrhagic intraperitoneal bleeding, right, inside the abdomen, and overall might be safer. But a lot of these procedures now, especially, like the robotic colpopexy, where a graft is used to attach the top of the vagina to the front of your sacrum, that is an intraperitoneal procedure. And so once that space has been opened, the chance that bleeding could occur within that space exists, although it's unusual, very unusual. But, if it does happen, sometimes you end up having to go back to the operating room to have that bleeding addressed, to have the collection of blood drained, and it's generally not life-threatening, but it is very disappointing, and it's a lot to go through. And so, the risk of that kind of hemorrhage is low, but it's a big deal if it happens. Anytime you have surgery, really anytime you get out of bed in the morning, the risk of death exists, right? With these kinds of procedures we're talking about, it's probably less than 1 in 10,000 that you would die as a consequence of the surgery that you're having. It's something to think about, highly unlikely to occur, but it is a finite risk anytime you have surgery. Anytime you have surgery, you could sustain an injury to surrounding structures. Obviously, your doctor is going to be extremely careful, and they have done these procedures thousands of times, hopefully. But despite that, sometimes surgical injury does occur. In my career, I injured one ureter in my entire career. I cut a ureter during a vaginal hysterectomy. I recognized it at the time, repaired it, the patient did great. But it's something that I always talk to my patients about before surgery. Potential for injury to surrounding structures like the bladder or the intestine or the rectum or ureters, blood vessels, nerves can be injured. All of these things can be injured. Generally, they're recognized at the time of surgery and addressed. But, sometimes injury to surrounding structures is diagnosed after surgery, and that put you at risk for a much worse outcome. And so, again, the risk is very, very low, but it is not zero. Blood clots and pulmonary embolism is a risk anytime you have surgery, and we use all kinds of precautions, to help that not happen. And despite that, sometimes people, especially after pelvic surgery, do get a deep vein thrombosis, or DVT, generally in their legs or in the pelvic vessels. And it's possible, if that happens, for part of that clot to break off and travel up through the heart into your lungs, and that's called a pulmonary embolism, and it's just a huge deal, life-threatening. How do you know if you have a DVT? Well, there's a few classic signs of DVT, like swelling in one leg, redness and pain in one leg, low-grade fever. If you were to notice those things after surgery, again, on the phone, doesn't matter what time it is, on the phone to your doctor. You'll probably get the answering service. You tell the answering service, I'm afraid I have a DVT. Trust me, you're going to hear from your doctor, or whoever's covering for your doctor. They're going to get you in the ER. They're going to do a CT. They're going to do a blood work. They're going to either make the diagnosis or rule it out. Your doc's not going to fool around with that. And so, but again, rare, but not impossible. Finally, pain. And this is sort of a tricky one because most patients having pelvic reconstructive surgery are dealing with some amount of discomfort. That's why they're having the surgery. It's uncomfortable. The problem, the diagnosis, is an uncomfortable diagnosis. Anytime you do surgery, you are going to disrupt some nerve fibers, and those nerve fibers usually heal without a problem, but sometimes the way they heal creates a new problem. For instance, you can develop something called a neuroma, which is sort of a nerve that's healed in an unfortunate way that creates lots of pain signal from the area where the nerve was cut. And we're not talking about huge nerves here, but tiny little nerve fibers in general, from where it was cut to your brain, and it can be a real nuisance and sometimes require further intervention. Sometimes even if you don't have a neuroma, as a consequence of vaginal reconstructive surgery, the caliber of the vagina, how wide it is, or the length of the vagina, how long it is, can be changed in a way that isn't entirely compatible with your partner's anatomy and make intercourse uncomfortable. So maybe, you didn't have that problem before the surgery. In fact, for a lot of patients with pelvic organ prolapse, it's just the opposite. There's not enough sensation during intercourse to get aroused, to have an orgasm. And so, your very experienced doctor has a general idea of the caliber and length of the vagina they're looking to restore and preserve. But, sometimes that doesn't turn out the way they wanted it or you wanted it, and pain problems, especially painful intercourse, can be an issue, and it can be a really big deal. And so this is something you want to have a real open dialogue with your doctor about before you make the decision to go to the operating room.